Welcome back to The Explainer. Okay, today we're rolling up our sleeves and getting incredibly focused. We're going to decode the latter half of the history and physical, the H&P, as well as the SOAP note. Look, we've gathered the patient's history, we've done the exam, but now comes the real moment of truth. How exactly do we synthesize all that raw data into a clear, compliant, and clinically actionable record that isn't just going to get bounced back by a coder? Let's master that today.
Now you might be wondering, why go so deep on this? Well, you've got to ask yourself this fundamental question every single time you close out an encounter. Is your documentation telling the whole clinical story? High-quality clinical documentation isn't just some administrative chore, and it's definitely not just about getting your billing right. It is entirely about painting an accurate, comprehensive clinical picture that actually drives patient care. Think about it. When another provider opens your note at 2 in the morning, does your documentation reflect the true depth of your clinical reasoning, or are they left completely guessing? Let's make sure it's the former.
Okay, let's dive into this. We're going to map this out chronologically, starting with documenting diagnostics and labs, then prioritizing the problem list, nailing down your assessment and diagnostic reasoning, the elements of the plan, and finally, formatting your ANP.
All right, Section 1, Documenting Diagnostics and Labs.
And this brilliantly illustrates one of the most common pitfalls we see out there. Just writing a generic statement like CBC is normal might be fast, sure, but it tells the reader absolutely nothing. Contrast that with the gold standard, actually documenting the specific values. You know, writing out WBC 5.8, hemoglobin 11, hematocrit 34.
So why the obsession with exact numbers? Well, there are 3 incredibly practical reasons highlighted in the source material. First off, it literally establishes a firm clinical baseline for your patient. Second, it empowers other readers of the H&P to formulate their own independent interpretations of that data. And third, it's a massive time saver. Seriously, if you just write normal, you're forcing the next provider on service to go on a wild scavenger hunt through the EMR just to find the actual numbers. Put it right there in the objective section, and you've instantly elevated your note.
Moving on to Section 2, Prioritizing the Problem List.
I like to think of the problem list as kind of an ongoing table of contents for your patient's health, but it needs a very specific anatomy to be useful. It's got to be a numbered list, prioritized by clinical severity, and it needs to include onset dates. And this is key. You absolutely have to flag the status. Is it active, meaning it requires your brain power right now, or is it inactive? Inactive problems are essentially resolved ghosts of the past, like say a surgery from 10 years ago. But they still provide totally vital context for the whole picture.
So the crucial point here is that number 1 spot. That top spot on your problem list must always, and I mean always, be reserved for the most clinically severe problem or the primary admitting diagnosis. Any brand new problems that pop up later, they just get added chronologically to the bottom. That number 1 spot is what sets the billing and clinical priority for the entire encounter, so you've got to get it right.
Right, Section 3, Assessment and Diagnostic Reasoning.
Now we get to the real brain of the note. The source text places a massive emphasis on the differential diagnosis, or DDX. Listen, even if you don't have a definitive answer yet, documenting your differential is critical. Why? Because it literally puts your clinical judgment on display. It explicitly demonstrates your higher-order critical thinking and provides the exact rationale for why you're ordering, say, a $2,000 scan. Remember this clinical axiom from the text? If it is never considered, it will never be diagnosed. Hit the nail on the head, right?
And remember, your assessment shouldn't just magically appear out of thin air. It's a direct synthesis. You're taking Step 1, the subjective history, and combining it with Step 2, the objective findings, to formulate Step 3, your clinical impression. Oh, and a quick pro tip for compliance here, your very first assessment listed usually needs to correlate directly with the patient's presenting chief complaint.
Next up, Section 4, Elements of the Plan.
So we have our assessment, now we need actionable steps. A truly robust plan of care doesn't leave any loose ends. It has to address every single problem from your assessment. It spells out the what next. What further diagnostic workup are we ordering? Are there consultations or referrals? What medications or therapies are we starting? And please don't forget patient education, because honestly, if they don't understand the plan, they're definitely not going to follow it. Finally, disposition. Are they being admitted or heading home with a 2-week follow-up? Get it all in there to ensure that continuity of care. Now, what's really interesting about this slide is seeing how all this translates into a real-world electronic medical record. We see a provider documenting an assessment for a calculus of the ureter, and it's followed by this highly detailed chronological narrative. It captures the whole clinical story, the pain, the imaging, and then flows seamlessly right into the current plans. We see the referral for lithotripsy, the preoperative clearance, the education. It's just a beautiful bridge between the clinical thought process and the actual physical interventions. Finally, Section 5, formatting your A and P.
Okay, let's talk about the structural mechanics. How do we actually put this in the chart? Basically, there are two primary formatting models you'll see. First, you've got the standalone format, where your assessment is one distinct numbered heading, and then the plan is a completely separate heading sitting right below it. Then, on the flip side, you have the integrated format. This is where you combine them into an assessment/plan, and you address the specific treatment plan immediately underneath each individual diagnostic assessment.
And people constantly ask, well, which way is the right way? The text gives us the definitive answer right here, stating, quote, either is acceptable and which is used depends largely on healthcare provider preference and whether documentation is paper-based or EMR-based, unquote. So rest easy. Both formats are completely compliant. It really just boils down to what you prefer as a provider, or maybe the specific template limitations of your hospital's EMR. As long as the core clinical info is there and flows logically, you are good to go.
So, we come full circle back to our ultimate question. Does your documentation truly reflect the depth of your clinical reasoning, or are you just kind of checking boxes to get the chart closed? Remember, your note is literally your clinical legacy for that patient. Protect it. Make it count. Thank you so much for joining me for this explainer, and please like, share, subscribe to Decode Healthcare with Harshal.